And it became clear that because there's no screening program for chronic kidney disease, many people only became aware that they had kidney disease when they needed dialysis. In a couple of cases, when we were talking to patients, within hours of feeling ill, they were rushed to emergency, and within hours again, they were on dialysis. And this because the symptoms of kidney disease only become obvious in the later stages of kidney disease. So we decided to change this. So working with the HSE National Renal Office, Diabetes Ireland, and we're funded from AstraZeneca, we launched today's World Kidney Day campaign called We're Counting on You. And Counting on You is all about asking people at high risk of kidney disease and their doctors to screen for kidney disease. Because as we'll see tonight, there are lots of options to prevent kidney disease from becoming kidney failure. So I'm going to run through the agenda and introduce our speakers. And you can see we have some very interesting speakers. So again, assuming the technology works, hopefully you can see the agenda up there. So the welcome and introduction, which I've just done, and then we're going to try and understand your interest in kidney disease and what aspect you're coming from. And then I'd like to introduce Professor George Mellotte, who is a clinical director of the HSE National Renal Office and a consultant nephrologist who has a keen interest in this area. And then we have Raymond O'Brien, who's a patient with chronic kidney disease, and he's a really interesting story to tell us. And then we have Juliette Duff, who is also a patient, but is also a doctor in Beaumont Hospital. So as Colin said, what I'd like to do is we let each of these really interesting speakers tell their stories, and you can put questions in the question and answer box, and then we'll have time to actually answer all those questions and answers. And Colin will facilitate that session. Colin is our National Projects and Advocacy Manager. And then we look for feedback on the meeting, because we want, as a patient-led organisation, it's really important to us that when we run sessions or when we do things, that is actually of interest to people, and we're getting it right or looking for ways we can improve on things. And then in conclusion, we'll have our chairperson, Colin Mackenzie, who is himself a volunteer and a long-standing champion of the Kidney Association, say a few words at the end. And depending on the length of questions, we estimate it'll take about an hour to an hour and a half, and we are recording it. So it will be available on our website if you have to leave at any stage, or if you have technical problems. If you're having technical problems, if you want to pop a question in, Colin hopefully will be able to assist. Okay, so I'm going to ask Colin now to launch the Zoom poll so that we can actually figure out where people's interests are coming from. So if you could click on where you're coming from, and you can click more than one option. Great, lots and lots of answers coming in. It's very evenly spread, actually. We've people with diabetes, people with high blood pressure, people with underlying illnesses that increases the risks of kidney disease, people who've been diagnosed with either chronic kidney disease or end-stage kidney disease, family members. We have healthcare professionals and students, and we have people interested in health education. So a good mix there in terms of the audience. So we'll try and address all of those interests. So that's great. So I'm going to hand over now to Professor Mellotte, and we'll ask him to give a presentation on how we can actually understand chronic kidney disease and how to prevent it. So over to you, Professor. Okay, you're muted at the moment.
Yeah. Thank you, Carl, for that introduction, and thank you, Colin, for organising this. And I'm really excited by this whole project. And whereas I know not everyone can tune in at this time, hopefully over the next few weeks, people can tune into this and learn a little bit. I've been given a broad brief in a short time to try and cover it all. So I apologise in advance if I rush anything. And, you know, ask questions, look for clarifications. And now I'm going to share my screen. Hopefully I can, where is it now gone? Sorry, show all. Why isn't it showing? Sorry, a second. Show all windows. I'm having a problem. Just bear with me a second, and I see what why I not see my my PowerPoint. And I might just open the PowerPoint again. And now look and see, can I share? Apologies, these technical issues. Share screen. Yeah, here it is here.
It's changing with Zoom every time you use it nearly.
It is, okay.
Great, we can see them now.
Okay, well, and I just want to make that smaller so I can see it myself. Okay, so I'm the National Clinical Lead for Renal Services. In other words, my job is to try and advise the HSE as to how we manage kidney disease. And I think one of my aims is to move the focus, in some respect, away from dealing with people with end-stage kidney disease or people on dialysis, which constitute a small minority of the patients with chronic kidney disease, and concentrate on that whole cohort of people who have kidney disease and who are not yet on dialysis and who never want to be on dialysis. And most of these patients won't be on dialysis. Less than 2% of people with chronic kidney disease end up on dialysis. The other 98% have other medical problems that need to be addressed and looked after. So hopefully we can get going. The first question is, what are kidneys and what do they do? They're often neglected. I was reading in the last couple of days, World Kidney Days, how many people didn't know what kidneys were, didn't know what they did, didn't know how you can survive with them or without them. So they're two small bean-shaped organs, each the size of about a fist, 11 to 12 centimeters. They weigh about 5 or 6 ounces, and they only 0.5% of your total body weight. But you get a lot of blood. 20% of the heart's output goes straight into the kidneys. And that is there because it's there to work and clean the kidneys. The unit of the kidney is called a nephron. They're very complex and they're not easily repaired. And once they're damaged, you have to go on to other units. And we're born with lots of spare kidney units and they wear out during time. There's 3 main parts to them. There's a filter known as the glomerulus that filters the blood. And the rate that the blood is filtered through this glomerulus is known as the glomerular filtration rate. And I'll come back to that, but that tells you how much of the kidney is filtering the blood. Then you have a tubule, a long twisted tubule, whose job it is to concentrate the filtrate into urine, put out the toxins that your body doesn't want, and reabsorb the stuff that your body has filtered back into the system. And then you have this tissue all around the filters, which makes various hormones that control a lot of things within the kidney. Normally, you're born with 1 million nephrons, and wear and tear throughout life means you lose some during your life. The kidney is the primary balancing organ of the body. It regulates everything. It controls everything. It removes your toxic waste products. And it gets rid of a lot of drugs, which is why when you've got kidney disease, some drugs can build up in your system. It removes toxins and it protects you against the effects of these toxins. It controls your blood pressure. It does this in a number of ways. It removes excess fluid from your body, and that's linked with salt balance. There can be a limit as to how much it can get rid of. And that's why giving it too much salt gives too much work to the kidney. It balances a lot of the minerals and chemicals in your body, controls the amount of acid and base in your body, your sodium, your potassium, your calcium, your phosphate, and your magnesium. These are all controlled by the tubules in your kidneys. And then it produces a hormone called renin, and that controls the blood pressure. It interacts with another system called the renin-angiotensin system and the adrenal glands, and that controls your blood pressure, and it's very, very important. It produced a hormone called EPO, famous because it was the cyclists were all accused of taking it, because when you get kidney disease, you stop producing your EPO and you become anemic. It tells the bone marrow to make more red cells. So it's very much a performance enhancing drug in some respects. And when you haven't got kidney function, you lack this performance enhancement. And that's why you often feel tired when you have severe kidney failure. As I said, it controls your blood pressure. I don't know why that's up again. But it also helps to maintain healthy bones. It takes the vitamin D that your skin makes, or the vitamin D you get from fish oils, or for wherever you get your vitamin D, and converts it into an active vitamin D called calcitriol. It also mediates the effect of a hormone which controls calcium and phosphate called parathyroid hormone. So it has a lot of different integral roles in how the kidney and how the body works. So what happens when kidneys don't work well? Well, the truth of the matter is that warning signs are extremely rare. There are some red flag lines, such as blood in the urine. That's always abnormal. You shouldn't have blood in the urine, and it needs to be checked out. Sometimes you can't see the blood in the urine, but your doctor can use a special test, and I'll come back to that in a little while to check for blood in the urine. You also may have a thing called frothy urine. Some people say they go to the toilet and after they've passed water, they notice a lot of froth in the urine, and that can be a sign of protein in the urine. Again, that's abnormal, and again, your doctor can look for that. Pain in your kidneys is actually quite rare, even rarer than what you might think. And usually if you get pain passing water, you get free, it's more likely related to your bladder and a bladder infection rather than a kidney infection. If you have difficulty passing urine, that's a warning sign. You should, because that could be causing back pressure into the kidney and damaging the kidney. So if you find it hard, you're standing up, trying to go to the toilet, and you're waiting for a few seconds before anything happens, that's a sign there's back pressure in the kidney, and you could be damaging your kidney. If your GP is struggling to control your blood pressure, that's a particular warning sign. If he's chopping and he says, and you need to make sure that he thinks and you think of kidney disease. If you're retaining fluid, it's often heart disease, but it can be kidney disease. But the message that most people, and we've talked about, and Carl has talked about this, is that early kidney disease has no signs and symptoms. And really, when you have signs and symptoms, to a certain extent, we have missed the boat. There's a lot of damage done. And as I said before, we can't undo that damage. The nephron unit is a very complicated unit. You want to preserve them early. And if we detect it early, we now have very powerful tools that slow the progression of kidney disease, slow the amount of damage that's been occurred, and in some cases can stabilize it completely. But in a lot of cases, it slows it down to what we would call natural aging, a natural aging rate. And the only way we're going to do that is by you going to your doctor and your doctor doing specific blood tests and specific urine tests. It's the only way to know. And these tests, they're simple and quick to do. I keep on telling my colleagues in the HSE, they're also amazingly inexpensive. And if you do it in the right people, you get a big bang for your buck. So what are these kidney tests we're talking about? There's blood tests. We're all used to going for blood tests and getting your blood tests checked. And you might get what's called a renal profile, or sometimes, and I prefer, a kidney profile. This is a test that measures kidney function. We measure a substance called creatinine. And from that, we calculate kidney function using a formula to calculate GFR. Another test that we might do in someone who's got kidney disease is looking at bone profile to check calcium and phosphate, because as I said earlier, the kidney controls your calcium and phosphate balance. And when you get kidney disease, your calcium and phosphate balance might go out of kilt. You might find your calcium level drops because you're not making vitamin D active. And if you're not making vitamin D active and you have a low calcium level, the calcium is leaked from the bones. So you get thinner bones. So it's very important to protect your bones by checking your calcium and phosphate. Certain kidney diseases can cause a high cholesterol because they leak protein. When you leak protein, you leak some of the control mechanisms for controlling your cholesterol. And we often have patients who they're thin, they're not on a high cholesterol, they're not on a high fat diet, and yet they have very high cholesterol levels because of kidney disease. So it's very important that we measure your cholesterol level as well. And your GP can often do these, but it's important that he looks at them. And particularly, we find GPs do cholesterol tests and they don't always do kidney profile tests. The second major test you want to get done is to look at the urine. Now, that can be done by a dipstick, which is a good sort of negative or positive screening test. In other words, if your dipstick is negative, in most cases, you don't have anything significant. You probably want to do a laboratory-based test if you're diabetic to detect very low levels of protein. Why is protein important? If you're leaking protein in your urine, it's a sign that the filter is not intact. The filter should stop you leaking protein. And therefore, if we see protein in the urine, we know the filter is damaged. Now, it can be damaged by diseases such as diabetes. It can be damaged by diseases such as glomerulonephritis. But it can also be damaged if the pressure of the blood coming into the filter is too high and the blood has been forced in it through too quickly. So that's another sign. So if we see protein, we know that there's damage being done there. So we will, if we see protein on the dipstick, we might confirm it with what's called a urinary protein to creatinine ratio or a urinary albumin to creatinine ratio. That tells us very accurately how much damage is going on in the kidney. The more protein we see, the more damage that's been done in the kidney. And if we have treatment that reduces the amount of protein in the urine, it reduces the amount of damage that's been done to the kidney. We also want to see is there red cells in the urine, because that means there's bleeding from the kidney into the urine. Now, the blood may be coming from the bladder as well, so we'd have to check out both. But we would look for those things to see what's going on here. We'd also look at your blood count to see if you've got anemia. Now, anemia can be many causes. It can be due to blood loss. It can be due to things like pernicious anemia. But in this case, we'd be worried about anemia due to the lack of the hormone EPO. So these are the type of tests we ask our GP to do. As I said, they're easily done and the results can come back very, very quickly, and that will decide what the next step is. Now, in the interest of time, I'm not going to go through what other specialized tests we do for specialized illnesses. I said to you that creatinine is the thing we often measure, but it's not a good measure of kidney function because two people can have the same blood serum creatinine, but they could have widely different GFR rates. And this is a slide that was sent to me by Paul Stevens in Stevenage in the UK. And he had two people. One was a little old lady and one was a very muscular young man who was into bodybuilding. They both had the exact same creatinine. One had very, very good kidney function. One had severe kidney disease. You might have heard of creatine, which a lot of young boys are taking these days to build up their muscles, and not so young boys. And it's incorporated into muscle. But as muscle breaks down, creatinine, which is a byproduct of creatine, is released. Now, the body has no need for that, and it goes through the kidney. And the rate it disappears out of the bloodstream is directly proportional to how well the kidney is working. So for any individual, your creatinine is relatively constant until your kidney function deteriorates. Now, it depends on your muscle mass. You know, as we get older, we tend to have less muscle. In general, females have less muscle than males. Depends on your body habitus. You know, you might be built like James Ryan or, you know, Aidan O'Shea, or you might be a little willowy female who has less muscle. So we have to look at these particular parameters before we decide. But the problem is that creatinine can go up a little bit, and the GFR can go down a lot, and you don't notice it. So we measured this thing called glomerular filtration rate because it's easier to notice declining kidney function. We have good research that shows the level of GFR correlates with the severity of complications. And in particular, it correlates with the severity of kidney damage. Unfortunately, we're losing about 0.5 to 1 mil of GFR, or 0.5 to 1% of kidney function per year from the age of 30 onwards. A lot of different reasons, scarring, wearing out, but this process can be accelerated by high blood pressure, and it can be accelerated by protein in the urine. A concern for doctors is that a reduction in muscle mass in the elderly may mask deteriorating renal function. And this is something we see on a regular basis. We see somebody who has been said, that kidney disease is not too bad, the creatinine isn't too high. But when you look at the patient and you look at their body size, look at their muscle mass, and you say, well, actually, their kidney function is a lot worse than what you think it is. There's multiple formulas, and they all this was the original, the Cockcroft and Galt formula, and you had to have an ideal weight, you had to have a sex factor, you had to have your serum creatinine, and you worked it all out. And you sometimes put in their real weight, and that was reasonably accurate. Then this other formula, which you didn't need to know the weight of the patient or their ideal weight based on their height, and was based on a standard body size, 1.73 meters squared. That was very handy for us on one level because the lab could do it for us. But it's a best fit formula, and it underestimates kidney function in young, healthy, muscular, tall males, and it overestimates kidney function. It can't be used in people who are pregnant, or people who've had amputations, or people with muscle diseases, people who've had strokes. So we have to be careful what we do. But with those caveats in position, we have classified kidney diseases 1, 2, 3, 4, 5. Now, there are other more complicated classifications. If I was giving this to a medical audience, that I don't want to go through because it just makes things very complicated. While we might think of eGFR as equivalent to kidney function, the problem is that these calculations are unreliable over 60, and it can vary very, very easily over 60. So in general, we don't think it's accurate over 60. Secondly, we don't think you've got real kidney disease unless it's below 60. So 60 is your sort of cutoff period before your normal or abnormal kidney function. Now, if you have some mild structural abnormalities, or if you've got protein in the urine, you might change a GFR of 60 or GFR of 90 and call it stage 1 or stage 2. But you can't call it based on the GFR alone. For GFR over 60, you have to have some other evidence to indicate there's something wrong with the kidneys. The definition of normal is once it's over 60 and there's no other signs of damage, such as protein in the urine or an abnormal scan, you don't have kidney disease. They start off with 3, 4, and 5, but in reality, we split 3A and 3B into 2 brands of moderate kidney disease, because particularly in the elderly, a lot of people in the 65 to 75 age group will have some degree of reduced GFR without necessarily having significant kidney disease. But it does affect how you handle specific drugs. Like if you're on a drug that has been got rid of by the kidney, for instance, and your GFR is 45, you find that it will last in your bloodstream twice as long as someone with a GFR near the 100s. People with severe kidney disease often find it very difficult to remove some of these drugs. So it's important to know that you got kidney disease. And I personally don't like the word failure. I just like to say reduced kidney function, severely reduced kidney function, rather than using these words. Because the kidneys haven't failed. They're still working. They're just not working as well as they should. When do you get symptoms? We really don't see symptoms until kidney function is about 30% of what it was when you were 25 to 30. Sometimes you might see it a bit earlier, but most times you don't see it until you're down to that level. So you've lost 70% at that stage. And as you go lower, as you go down to 10 and 15, the symptoms get worse. Commonly, people complain of an itch, sometimes a very frustrating itch, yet the skin looks perfectly normal. They may be tired due to the anemia. They may have nausea, poor appetite. They often have mental health issues, apathy or depression. You get fluid retention, and particularly for diabetics, you may see changing insulin requirements because insulin is got rid of by the kidney. And sometimes with diabetics, they find that they don't need as much insulin because their insulin is lasting longer in their bloodstream. So how do we protect your damaged kidneys? This is one example of how we might protect damaged kidneys. Here is, Joe blogs, and he has a nice big beer belly, and he is eating McDonald's and fast foods and not doing enough of exercise. That leads to a whole cascade of different effects. It affects his heart. It pushes up his angiotensin level, which is with the kidney. It works on the kidney. You retain salt. Your blood vessels become stiff, and it leads to a whole pile of other problems and pushes your blood pressure through the roof. It affects your cholesterol. You eat a nice diet, you lose the weight, you take salt, the heart has less work to do, and the kidney has less work to do. So what does that mean in real terms? Sorry, sorry, excuse me. What's going on? Okay. So this is an example of something we might do in the clinic. Now, this is a program made primarily for heart patients, but the same thing happens to kidney patients. We take Joseph O'Connor, we'll call him Joseph O'Connor. He's 50 years of age. He's smoking 20 a day. He's very high blood pressure. His cholesterol is up, and he's got kidney disease. We'll calculate, Joe, you have 13 years before you're probably going to get a heart attack. You're in deep, deep trouble. And Joe says, hold on, I'm only 50. You're saying I'm probably not going to get to 64, and I'd probably be, dead, a good chance of being dead in my 70. Don't like those odds. So let's stop smoking. Let's aggressively get your blood pressure down. Let's put you back being fit. Smoke. Stop your smoking. Get your cholesterol down. And when you stop smoking, your HDL cholesterol go up. That's your happy cholesterol, your healthy cholesterol. Here's what happens. He quits. His blood pressure is right down. His cholesterol is right down. His good cholesterol is right up. And we can tell him, you've gained 17 years of extra life. You know what I mean? This is the type of thing we do in clinics, at least I do, when it's not too busy, is saying, look, you have your choices. You can do this or you can do that. So who should be asking? Who are the risk groups? Diabetes is a risk group. Particularly type 2 diabetes, particularly if you have it for a good few years. On average, 1 in 3 people with diabetes develop some degree of kidney damage, particularly after 10 years of diabetes. The problem is that you may have had diabetes for a lot longer than what you know you've had. But if you've got diabetes and you're over 50, I would certainly be knocking on the door of your GP and saying, what's my kidney number? And you should track it yourself and see what it tells you. It is a problem with people with high blood pressure, not quite as bad as diabetes, but it is a problem. But if you've got the two together, you're now in a 50-50 chance of having chronic kidney disease of some description. And again, this is like a yellow card. The first is a tick, the second you're on a yellow card. Being overweight is a risk factor for chronic kidney disease. And again, it's because the kidney is asked to work harder and it's wearing out faster. If there's a family history, there is probably some sort of genetic disposition, particularly if you got those three diseases that we haven't fully are aware of, or there may be a family history of some disease, such as polycystic kidney disease or something else. Again, look at it. Some of the inherited, like if reflux infections of childhood can cause kidney disease, and they often run in families. Certain ethnic groups are at high risk, particularly the African American, the Central African patient, because we don't handle the salt, which is in our diet, very well. The Western diet is a high salt, high sugar diet, which is particularly damaging to the people of Central African descent, African American. It is a particular risk factor. And these people, you know, look at them. What can you do? Don't accept, sure it'll do. And you haven't got white coat hypertension. If you've got kidney disease, you've got hypertension. It's not white coat, because the definition of white coat is high blood pressure without damage to a target organ. The kidney is a target organ, and by definition, you can't have white coat. You've got to get the blood pressure down, because if you don't, you're losing years of life. Every 2 millimeters of blood pressure over target is robbing you of a year of life, or 2 years of life in some cases. So you've got to get those 24 hours. You've got to be strict on yourself. Strict blood pressure control. When you get strict blood pressure control, you keep that kidney alive. And I'm very passionate about that. And it works. I've seen it work. I've seen people who were looking down the barrel of dialysis, not going down dialysis for 10, 15 years. Lose the weight, do the exercise. Target is a BMI less than 25. It's not one of the 10 commandments, something to aspire to. You've got to do it. You've got to stop, avoid salt, processed foods, got to stop smoking. Kidney disease is a vascular disease. Smoking is a vascular toxin. The two together is going to put you in a grave earlier. And if you detect kidney disease earlier, we have novel treatments. We know, for instance, that one of the blood pressure tablets we use are a class of them called ACE inhibitors and angiotensin receptor blockers. Slow the rate of progression by up to 20 to 30%. There's other new tablets coming along that are also shown to slow down kidney. And the future is that these may come together and really slow down the progression of kidney disease. And obviously we control cholesterol. It'd be a bit of a shame to control your kidney disease and get a heart attack. I've been asked to talk when kidneys fail, and I'm conscious I've been talking for a while, so I'm going to quickly run through some of these things. The first point I want to say is that dialysis removes waste products and unwanted water, but it doesn't replace the other functions of the kidney. So it comes with other things like injections for EPO, diet, calcium, phosphate, vitamin D. There's a lot of things you have to do and tells us that. How do kidneys fail? It's usually a slow process, but the kidney failure is often independent of the disease that caused the initial disease. But the problem is that an acute severe intercurrent illness can precipitate a sudden collapse in kidney function. You know, someone who's got mild to moderate kidney disease gets very unwell. We saw it with COVID. We saw it with people with cardiac surgery, and then suddenly it tips them over and they go into severe renal failure and don't recover. When do we start? A bit like that cat, a gun is put to your head. But normally when you have unacceptable symptoms, when kidney function is somewhere between 8 and 10%, your creatinine around 400 or 500, or if your potassium level is going too high, or if you're not eating. And it depends on quality of life. There are choices. You know, hemodialysis, it's done intermittently. You come in, you come out, and I'll go into that. It's complex and it's based in a hospital. You don't always tolerate it very well if you've got cardiac disease, and there's a problem of what we call vascular access. Peritoneal dialysis, it's simple, it's independent, but relies on the patient. And there are issues with it. And I might just, in the interest of time, skip on a little bit and talk to these in another slide. Transplantation is desirable, but it's a scarce resource. One of the things I want to say, it's not a cure, it's just a different way of treating kidney failure. And there are risks. I'm an advocate for peritoneal dialysis. It's a home-based system. One of the interesting facts from the last 2 years is that nobody on peritoneal dialysis died from COVID, at least as far as I'm aware of. You have a catheter that's put into the cavity around your gut. It's called a peritoneal cavity. We supply sterile dialysis fluids. You do it in your own home, and you may need a pumping device or a heating plate. This is done usually 4 times a day, spread throughout the day, and you do it 7 days a week. This is done using a machine at night. But increasingly, we're giving people little nights off or days off, because if their own kidneys are doing a little bit of work. This is the machine here with red and green buttons on it, stop and go. So again, it can be this not all patients can do APD. There's no survival advantage of one compared to the other. Hemodialysis is the traditional one that we see in the hospital. Sometimes people train up and do it in their own home now, but there's only 50 to 60 people doing home-based hemodialysis. I'd like that number to be higher. You need what's called a vascular access, a way to get blood from the patient. Either put in a type of large bore catheter called a perm cath, or you create a thing called an AV fistula, which is a way that you strengthen up the blood veins so that you can put needles into these veins on a regular basis to get blood from the patient into the machine. The machine pumps about 100 mils of blood through a special hemodialysis machine, and it cleans the blood using an artificial kidney. Each treatment takes typically 4 hours. Some people get away with a little bit less, some need a bit more. And there's the traveling time, which might be okay if you live, if you live in Tallaght or you live in Salt Hill. But if you live in Clifton or you live in Athy, it's going to take you an hour and a half to get to your nearest renal unit. And it's done on an alternate day basis, Monday, Wednesday, Friday, or a Tuesday, Thursday, Saturday schedule. Kidney transplantation is a holy grail, but you have to be fit for it. And on average, only about 30% of the patients on dialysis are deemed to be medically fit for kidney transplantation. The waiting time has extended between 6 and 24 months. Transplants are done in Beaumont. Ideally, you'd commence workup early. We can refer when the GFR is 12, just to be 15. But there's a lot of work to be done to make sure, because what you don't want to be doing is putting someone who's going for a transplant in for a coronary artery surgery after the transplant. So you get all this work up done beforehand, make sure that the plumbing is okay, make sure there's no gallstones or anything like that. And we do some tests for cervical cancer and some other tests. The good news is transplantation has become boring. It does what it says on the tin. It works well. Acute kidney rejection was something I learned a lot when I started doing kidney medicine. Now it's thankfully rare. Our biggest problem is organ shortage. There's a long waiting time. And even living organ donor, there are bottlenecks in that. There are long-term complications, increased risk of infections. Again, we saw this during COVID, increased risk of getting cancers, increased risk of cardiovascular, but some of that is the type of person who gets kidney failure as a diabetic or someone with high blood pressure. They're at increased risk of heart attacks anyway. And it's a continuation of the risk that brought them into kidney failure in the first place, rather than the kidney transplant accelerating that risk. The transplant kidney can wear out. one of my long-term patients, who I first knew as a registrar, ended up going back on dialysis after 34 years. And I felt very sorry for her because she had a very eventful 34 years. I knew her just after she got her transplant. And she said to me, well, what did you expect? So that kidney was nearly 90. The good news is I'm able to say that she actually got a second kidney and she's doing very well. We sometimes hear the phrase chronic rejection. But it's often just chronic wearing out of the kidney rather than a chronic rejection process. But the reality is that most people who get a kidney transplant, it gets them to the end of their life. And the transplant fails in theory because the patient dies from old age or something else. As I said, I was given about 15, 20 minutes, and I hope I've kept to time and ran through this so we can have plenty of time for questions. Right. Today's World Kidney Day, and it's going to one last slide. It's going to be a huge public health problem. I got this fact sheet a few years back. The amount of 5,000 new cases of diabetes every single day, 180 non-traumatic limb amputations, 133 people begin treatment for dialysis every single day. So, these are what we're trying to avoid. And early intervention will prevent all this. So I'm going to stop at that.
Great. Thanks very much, George. There's loads and loads of information on that, and I could see questions are starting to come in, but we're going to hold on those, and we're going to quickly go to Raymond. Raymond is a patient who has a fascinating story, so I'm going to hand over to Raymond now.
Lovely. Hi, yeah. My story is I'm 55. I'm married to Etna. I have 3 kids. Isabella's 11 and the twins are 9. I'm a diabetic type 1. I was first diagnosed as being a diabetic in 1987. I was cruising along with no complications for years. I had a few eye problems, whatever, but then about 15 years later, I was into my Professor Tim O'Brien in Galway, who's my diabetic consultant, and he was running tests, and he did a kidney function test on me, and we found that my kidneys were starting to go into failure. So then I was put over to George Mellotte there. I started seeing George for, I don't know, 15, 16 years. I was tracing up to Dublin 3 or 4 times a year. And initially, when I first met with George, he says, okay, yeah, your kidneys are on the way out. You're going to have to get dialysis within the next 1.5 or 2 years. And we'll treat you and we'll do our best for you. And, when you go on dialysis, we'll talk about home dialysis or whatever. And so my wife was with me at the time, and she said, well, why don't we just rip it out now and put in the new kidney? And George stopped her straight away and said, listen, I know what you're thinking. You're thinking of giving one of yours. And he goes, we can't give it to you because our kids were really young at the time. So that was that. So next, George started telling me about, lifestyle changes, and the big one that he was mentioning was blood pressure. He says, your blood pressure is up. We're going to have to bring it down. We're going to have to cut out salt. We're going to have to, everything that George had just talked about earlier on. So I said, okay, I'll get on board with that. So I every morning at 8 o'clock in the morning, I've got one of those cuff blood pressure things, and I check my blood pressure every day, and I used to send them on the results to George. And from that, we got my blood pressure down, and I stuck to my diet. We bought a camper van so that I wouldn't have to eat out. I just was really strict with everything. And with that, I lasted 15 years without actually having to get dialysis. And at that stage, my kidney function had gone way, way down. And I had told my family about that I was going to need a kidney. My brother stood up first and he said, yeah, I'll do it. But he was ruled out because something didn't match up properly. And then my lovely sister, who's my hero, she gave me a kidney, and she was actually a perfect match. And that was in 2017. And, you know, straight away after getting the new kidney, I was a new man. I had tons of energy. Just didn't know myself. So I'm the kind of the poster boy for saying that early detection, it does work. You know, it does slow down things, but you have to be strict about it. You have to kind of do it with, you know, the likes of George Mellotte or any other nephrologist, whatever they tell you. It does work, but you have to be strict to yourself. And that's my basic story, really. I don't know what else I can tell you.
I'm sure there'll be questions, Raymond, from the audience, but it's a great story because it shows George was saying, and, you know, I'm so pleased that for once George was wrong, telling you that you were going to be on dialysis in a year or two, and by doing the right things, and it was a discipline, but because you had the support, you were able to take action and delay dialysis for over 15 years. So it's a really impressive story, and it's really something we in the Kidney Association, we really want to get into helping people more to actually prevent going on to dialysis. But that's another day's story. And
but it was the early detection that got us.
Yeah, that's the key. That is the key. So a great story. So thanks for that, Raymond, and we'll be back to you, I'm sure. And now I'm going to hand over to Juliette. Juliette has another very interesting story from another different angle. So Juliette, would you like to tell your story?
Yeah, thanks, Carol. So thanks so much for having me here. So my name's Juliette. I'm 27. I'm about 4 years transplanted now, and I'm working as a very, very junior doctor at the moment. In Beaumont Hospital, where I had my transplant. So it's funny how it came full circle. So I was diagnosed with kind of end-stage kidney disease about the age 19. So I hadn't really been myself for a while. I couldn't really put it down to anything. There'd been a couple of visits to the GP where I just couldn't even explain what was wrong. I just wasn't right. I was tired, I had brain fog, I was getting lots of headaches, and I just kind of felt very off. Looking back, I was getting up a couple of times a night with very, very frothy urine, which is probably the kind of thing that jumped out at me once I realised what was going on, that had been quite obvious. So like Prof. Mellotte said, that was kind of staring me in the face then. But these GP visits weren't really getting anywhere. I kind of thought it was all in my head, to be honest, until kind of one time during my leaving cert year, about the age 18, I had very high blood pressure, and it was put down to white coat syndrome. I would have probably been kind of a bit of an anxious person. I was really focused on my exams that were coming up in a few months. So that was that. He said, look, go back, do your leaving cert, and we'll check it again in a few months. So I kind of did the leaving cert. I got into UCD science and I was having a great time, and I didn't really want to go back. I just thought, look, I'm just being difficult. I think every young girl feels this way. But no, my mom wasn't happy. She knew something wasn't right, and she said, go back to the GP. So I went back reluctantly on New Year's Eve, and he was like, your blood pressure is still incredibly high, and it was very high at this point. So the GP, he was on the ball. He said, look, give me a urine sample. Well, actually, sorry, first he said, was there any family history? And my dad had kidney failure. He had two transplants at this stage. And at that point, the GP was like, right, we're getting urine off you. He was very unhappy with kind of that presentation then. And lo and behold, there was a lot of protein, a lot of hematuria blood in the urine. So I was sent straight over to St. Vincent's A&E, and from there I got a diagnosis very quickly. So I think kind of because my dad had come from a very big family, lots of siblings, he was the only one with any hint of kidney problems. It was never once considered that this could be something that could be passed on to me, or you know, any kind of future family. But I think that GP just put two and two together then, and the fact that it was so simple, and I'd been to the GP so many times, I was amazed how easily they could then find out with that one urine test. And it just struck me then and there that it was so simple to kind of pick this up. So I guess then I had all kind of further tests in hospital, and it was such a relief to have a diagnosis. My parents were so upset and they couldn't figure out why I wasn't more upset, but I think it was the fact that I finally had an answer to why I was feeling this way. We could do something, and it was like, this isn't just me being difficult. So getting that diagnosis, that one simple urine test, just kind of actually was a huge relief for me. And the team in St. Vincent's looking after me, they were absolutely fantastic. They said, look, we can do things like this. I was put on an ACE inhibitor. I was given my EPO because I was extremely anemic at that point. And I think I did stay well for longer. I managed to go off and do my HPAT and get into the course I wanted to do. In that kind of year between getting a diagnosis and starting to be prepared for dialysis, I moved to Galway and started doing kind of my course there, and there were just so many things that I could do because I was kept that bit kind of better for longer. So I was then kind of prepped to do peritoneal dialysis, and again, that was just such a blessing. It let me just kind of go out and experience my early 20s and kind of get a lot of the freedom that goes with doing dialysis at home at night. And again, I think that's because that bit of time allowed them to kind of tee me up for that. I did end up requiring dialysis a lot quicker than expected, but I do think there were just a lot of things that were done in the interim to just help me feel better. I actually felt so much better once I got the diagnosis than how I had for the previous year or two. So it was really wonderful for me. And yeah, I'm trying to think if there's anything else I can include in that. But I think one thing that you asked me to mention was there anything I'd say to people who are just kind of finding out they have kidney disease now? And I think it's just that it's obviously it can be very difficult for people. For me, like I said, it was a bit of a almost relief and a blessing to know what was going on. And I had my dad to look up to, who had been through dialysis when I was a child and had been through a transplant, and I got to see that he could live really quite a good life with that transplant. And I think it's just that do everything you're told. If you're getting that diagnosis, cut out salt, and if you're put on that phosphate diet, keep taking those phosphate binders and do all those things. They're really important and they do make such a difference. And yeah, I think just listen to the advice like Raymond said, and it's not the end of the world. It might be kind of the end of the world as you knew it, but you can have just a really good life if you look after yourself. So yeah, thanks so much.
Great, thanks, Juliette. And obviously it must have been very tough to be so young and diagnosed with this disease. But as you said, you know, you were going around the system for a little while before this very simple test picked up that there was an actual problem. And I've heard the leaving cert being blamed for so many problems in patients when it's not actually the leaving cert at all at times. So it really shows the importance of doing this very simple blood test. So thanks very much, and your story is very inspiring that despite being diagnosed with this disease, that you're able to go off and like Raymond, have a very high quality of life, and you know, are now working in the healthcare system. So I know we have a few questions, so I'm going to ask Colin to unmute and put those questions to the professor.
Right, George, you're in the spotlight now. We shall test you. Now, looking at the questions that have been coming in and some questions we've received in the office during the week, I think the real focus has been on the rate of decline. Like, one of the questions is talking about, like, they've got to 15% and like, could they stay there? Are they going to slip further? Or we have somebody who's been classed as 3B, and like it was picked up accidentally that they were the kind of 3B on the scale, and they've been monitored for quite some time. And again, they're wondering kind of, is this usual, unusual? So I guess it's to do with the rate of decline and whether there can be kind of plateaus or can it stop?
Yeah, absolutely. It's a good question. And there's 2 or 3 things that determine whether or not you're going to progress. First is how well you control your blood pressure. Now, I was trying to get it all in But there's studies going back to the 90s. If you blood pressure averages, say you've got kidney disease, chronic kidney disease, 3B or 3A, and your blood pressure is averaging 150 over 100, say, you're probably going to lose 6 or 7 mils of GFR per year. So you can do the maths. If you're running around 50 and you're losing 6 and 7 a year, in 6 years you're going to lose 36, and you're facing down the barrel of dialysis. If, however, you get your blood pressure down to 140 over 90, you'll probably go down to 3 mils. But get it down to 130. That will really, and use the ACE inhibitors, and possibly these new drugs we're talking about, you can get it down to maybe a half to 1 mil a year. So hold on a second, you were 50 and you have a GFR of 50 and you are 50 and you're losing 1 mil a year. Well, in 30 years' time, you'll still be in fairly decent shape. So that's good. That's why early detection works so well. The other factor in this, however, is proteinuria. For every gram of protein you lose, you're adding another % kidney function loss per year. So if you're losing 2 grams a year, you're probably losing 2 grams per day, you're losing 2% kidney function. Losing 3 grams, you're losing 3 grams. So that's a big, big factor. So if you get that proteinuria right down, getting your blood pressure down, getting your ACE inhibitors, getting your blood sugars right, you can really, really slow that down. And I mean, Raymond won't mind me saying, when he came to me first, he had proteinuria of 3.5, 4 grams per day. And we got that right down to, I think, about 0.3 per gram. So instead of losing, his rate of decline went down tenfold by our early intervention. And that's what you can do. In actual fact, there's a medical tool we have ourselves called the kidney failure risk equation, which we use. It's called kidneyfailureRisk.com. And that uses your age and your blood pressure, what your current kidney function is. And we can use that sometimes to predict who do we need to follow up in clinic, or who can we safely discharge. So if you can get the blood pressure down to the 130, 125, 130 mark constantly, confirmed by 24-hour BP, get the proteinuria down to less than a half gram per 24 hours, you can bring your rate of loss of kidney function. In most cases, not all, I can't give you that guarantee. In most cases, you can bring it down to normal aging rates. So I have anecdotally kept quite a few people with GFR at stage 4 for several years without them progressing. It's not automatic, but there does come a point, I will admit, when you get down to very low figures, you can't get the proteinuria down, no matter how much blood pressure control you have. And in that case, you're fighting a losing battle. So you have to get the blood pressure down and you have to get the proteinuria down. Hope that makes sense. Both have to get down. Getting down one will help, but you have to get both down. If you can't get them both down, you can't get them both down.
So we saw from the poll at the beginning that we have a number of kind of family members on, and it's often an issue for our family members, kind of, what can I do? I'm kind of here on the sideline watching, how can I help? So in terms of the practical kind of lifestyle, etc., like you're very clear on the removal of salt, and like all the years I've known you, it's been kind of very clearly one of your passions, and rightly so. But what else? Like how can a husband, a wife, a mum, a dad kind of play their role in kind of adapting circumstance to help control the likes of blood pressure?
Well, I would personally say it's very hard to stick at a diet, to be on a diet and someone else eating a full, like you're asked to eat, your potatoes and your bit of meat, and the other person is ladling on the tomato ketchup. You know what I mean? I think, let's put it this way: you've got to do the same thing together, eat the same meals. It's got to do yourself good health in the same time. Exercise together. Go out and exercise together. Eat the same. What we're talking about is healthy eating, and buy into it both. And I would be very passionate about that. Do the exercise. Don't smoke. If your partner is kidney failure, you shouldn't smoke. You owe them that, because if you smoke, they may smoke. You know what I mean? these things work together. It's a partnership. And I think these are things that you would want to say. That's the main thing I would say is go on this together, exercise together, eat the same type of foods, and you're doing yourself, both of you are doing yourselves a favor.
Yep. That kind of covers all the questions we have in at the moment. Carol, I don't know if you want to.
Yeah, just one question. Nobody mentioned about alcohol. Is alcohol a risk factor?
Well, alcohol, I'm going to be very, very politically. Alcohol to me, there's two things about it. One, yes, a small amount of alcohol is probably relaxing. There's some perceived health benefits for it. And I'm not going to tell people to stop drinking alcohol completely. But I would also say it's a Mars bar in a glass. A glass of wine and is sort of half a Mars bar or 3/4. And if you're trying to lose weight and you're drinking alcohol, you know what I mean? You're giving sugar, you're putting pressure on yourself. Like, let's put it this way, you probably won't eat 5 Mars bars, but you could easily eat the equivalent of 5 Mars bars by having a few glasses of wine. So I think you've got to look at it in a lifestyle. There's good evidence that a small amount of alcohol is probably it doesn't do you any harm and helps you relax, but certainly large volumes of alcohol puts on weight, push up your blood pressure, damages you. If you're on a fluid restriction, it's fluid. I'm not going to ban it completely, other than it is a Mars bar in a glass for some people.
Right, thanks.
Sorry to disturb those people who like the glass of wine.
I think there's now such a thing as low calorie wines, and there's also low alcohol wines. So maybe as they become more popular, I believe some of the low alcohol wines are actually quite palatable at this stage. You can even buy them in Lidl, apparently. So that's great.
I've been asked, and I feel this is very self-serving in asking this question, but somebody has put it into the Q&A to kind of promote the fact that the Irish Kidney Association does run a sports program under the banner of Transplant Team Ireland to encourage activity. And it's physical activity very much at the level of the individual, as opposed to kind of pure lethal kind of competition. So there is a forum there for people who are on dialysis and who are post-transplant. So that's there. But I think the key messages I'm taking out of this evening is be proactive and engage with your healthcare providers. And like we've seen from Raymond and Juliette, that a real difference can be made. It's very encouraging.
Right, thanks, Colin. So before I hand over to our chairperson, Colin Mackenzie, for a final few words, I'm going to ask Colin to run a poll to get your feedback. Really, really important. So many people have stayed with us, so hopefully you have found it interesting. The session is being recorded, so anybody with technical difficulties, it'll be on our website probably from tomorrow evening. They'll be able to look at it. Just go to ik.ie kidney health, and you'll find it there. There's a whole load of information there, and you can download patient information leaflets. If you have any other questions, don't hesitate to give them to us. So if you could fill out your satisfaction with the webinar, I'd really appreciate it.
And Carl, thank you very much for this opportunity. And can I say, don't be afraid to check those numbers, because knowledge is power. And if you know your number, you can do something. And if you can slow the rate of progression, you can avoid dialysis in so many cases, and you can avoid having early cardiac events, like we call kidney disease a risk identifier and a risk modifier. People who've got diabetes, people who've got high blood pressure are more likely to get complications if they've got kidney disease. So by knowing this information, you can prevent and avoid all these other complications. So don't be afraid to get these numbers checked, because all you can do is benefit from it. Great, thanks very much, George, and it's great to have you here. And it's been
As I mentioned at the start, we've been working with both Diabetes Ireland and the National Renal Office to develop this campaign. And it's not just aimed at patients, it's also aimed at GPs as well. So when you go to your GP, hopefully they will have heard about checking kidney health, because we know they're so under pressure that sometimes, as Juliette saw, they don't get it right the first time. So the results of the poll are in, and 96% of people are very satisfied with the webinar. So that's terrific, and everybody else was somewhat satisfied. So we're delighted with those results. I'll just share them now so you know I'm not making it up. You can see them there. So that's great. And I will confirm that there was a question asked to promote the Transplant Team Ireland. We give Colin an awful time for being so passionate about the transplant team sports, but it is a great social outing and a great support group for people. So I would recommend it to people. So before we finish, I have thanked everybody, but I'd like to hand over to Colin Mackenzie, our chairperson, to say a final few words. So I'll just ask you to unmute, Colin. Great, you're muted now.
Okay, have you got me? Yes, okay. Yeah, I can't stop thinking about Mars bars. Professor Mellotte, you shouldn't have mentioned them. There's two types of Mars bars, as I'm something of an expert in this area. There's the large one, but you can also get, if you're obsessed with Mars bars, you can also buy a packet of small Mars bars. So that might help you in your lust for a Mars bar, right? But I was so interested to think that I know an awful lot of people drink 4 and 5 glasses of wine often every night, so I don't know what condition we're in at this stage. But anyway, no, I think World Kidney Day, just touching on that for a moment, I think we've always been aware of World Kidney Day. We actually really haven't done much about it in the past. And I think it's a great thing that we are doing it, because it is the World Kidney Day, and maybe in time we can link up with other European bodies, especially, who are involved in World Kidney Day. And I think it's something that can be expanded. I'd like to say also to thank, just before I forget, to thank Carol and Colin for their, and the staff for their work, because nothing goes on easily, you know, behind the scenes of all these things that look so simple. There actually there's always a lot of work and preparation as well. I want to thank George for the clarity and the interesting presentation, even though we've all sort of have a knowledge of it. At the same time, none of us have completely, well, those of us who are not professionals haven't got and it's good to hear all the details again to remind us what's involved. So I'd like to thank you for that. And also to say to Raymond and Juliette, I think it's always interesting to hear. One thing I noticed, and I'll just give you a little anecdote. Occasionally, my wife and myself have been asked to speak to groups about transplantation, the transplant journey that she has been on. And I stand up as the sort of one of the national officers, and I give a spiel about the Kidney Association, etc., 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 and everybody's terribly interested, and that's it. But my wife, then, Tricia, gets up and she tells her story. And there's a kind of a hush over the room that wasn't there when I was speaking, because every transplant journey, they sound the same, but they're all different. As you can see, the Raymond and Juliette are two different stories. And I found that every kidney patient has a different story. So it's so important to keep telling the story. And for that reason, I think what we're doing this evening is very important. So George, thank you yet again for your eloquent speak and talk about it. And we will all try to keep educating ourselves, especially in the area of Mars bar consumption. Okay, thanks very much.
Okay, well, that's it, folks. An hour and a quarter, so we kept within the time scale. So thanks so very much, and we got some nice comments in on the chat function, so that's great. So thank you all very much, and hopefully we will see you at a future webinar at some stage. Thank you.
Okay,
Great.
thank you, Carl.
Thank you. Thanks very much, everybody.
Okay, bye.
Bye-bye.